I was lucky enough to run a transitional facility for people who were being discharged from the 2 spinal injury units in Sydney, and then who spent between 12 to 18 months with us in a transitional sort of holding accommodation facility where we beefed them up, got them into education, training, rehab programs, and did all sorts of things, and then kicked them out into the community with all the appropriate support. So that was probably my first experience of looking at a rudimentary hospital-driven model of integrated care that ended up into the community. And back then we used things like the locus of control model and some of the writings of people like Roberta Treichman to get a sense of where people were in their almost predicting what they were going to be like in terms of dealing with this catastrophic injury. I then spent quite a long time, around about a decade, working with a large multinational manufacturer looking at R&D projects in pain and regional anaesthesia, and it was an interesting breath of fresh air to go from a publicly funded to a privately funded organisation, and then came crashing back to reality working as a consultant, and since then I've been working in primary and secondary care services, looking mainly at the alignment of services from the different consumers of those services, which is a particular interest area of mine. And a number of the areas that I have an interest in are working in aged care, mental health, CALD communities and the different ways in which they use services. The things that I like to talk a bit about this afternoon, which are meant to set the scene for this afternoon session, are the work that I'm doing with 8 different Medicare locals in looking at the interaction that they have and the support and the experiences they have with allied health, general practitioners and hospitals. When Lewis asked me if I would do this talk, I was promised a morning spot. And this gives you an idea of the desperation that people in the post-lunch time spot have when they're thinking of what to put up on screen. Hands up if you can remember playing with that toy where you got a piece of string and 2 tin cans. Hands up if you remember thinking, I hope I get a better toy for Christmas than this. Okay. Well, back in that time, your family might have had an E.H. Holden. The typical dinner beverage on the table might have been a 750ml long neck of Riche's DA, and your household would have had a razor blade in it. It wasn't a razor blade that was sewn into a tam o' shanter like Norman's mates would have had in Glasgow, but the razor blade was there for registration time. So back then, consumers facing registration had to go to the garage, get the pink slip out, pay the mechanic the $100 to fix whatever it was, that there was always something, and then go through the process of going down to the motor registry and getting the sticker, and that's where the razor blade came in, because back then you had pure glass which would shatter beautifully in an accident, but you could also scrape enthusiastically with a razor blade. The reason for talking about all that is that today, I think this year, we marked the abolishment of registration labels in New South Wales. So it's all electronic. We can go online now. We can, if a car's less than 3 years old, we don't need to get inspected, and we can organise all that quite seamlessly. The green slip, the insurance, the registration and the inspection are all something that is done for us, and we don't even need to go into the motor registry. So it gives you an idea of where a number of consumer journeys in areas other than health have progressed quite quickly. In health, we still have a few areas where we don't see that same sort of speed of progress. I'm going to talk about 3 different aspects. Patient journeys, and I want to try and pick up on some of the things that we talked about earlier on our table, which was rudely cut short by Norman when we were talking about the results. But we started talking about the importance of patient journeys, so I'm going to give a couple of examples from some different areas. I'd then like to talk about some of the things that we've been measuring for some time now, which look at the drivers of interaction effectiveness. And then I'm going to finish not with some solutions for opportunities in integrated care, but perhaps some suggestions on some frameworks that you could then consider as you go through in your workshops. I'll talk about some areas in mental health, in joint replacement surgery, and a little bit about Hep B and selecting care providers. I only came across this the other day, but I don't know if anybody has noticed that the BMJ have been publishing lessons from patients' journeys in their journals for around 6 years now. And the whole idea is to get patients to talk about their journey, what went wrong, what went right, and use that as a way to try and convey a patient voice or a consumer voice to the medical profession. When they first started, it looked like something out of the Sunday supplements, and some guidance was given by the patient editor, Peter Lapsley, to try and improve the quality. And then to improve the perspective even more, what is now added into each of these articles is the doctor's perspective, where the treating doctor is able to comment on what the consumer has said about their hospital treatment and their process. So it's quite a powerful dual view of their experience. And some of the things that have come out of that are the time to arrive at a correct diagnosis, and the emphasis that consumers have on wanting to have something as a label, but the comfort that some clinicians have in not having a precise diagnosis, and the difference between those two. And then some aspects of conditions and diseases might be much more important to consumers than to clinicians, and recognising the impact of those. And there's a good quote: doctors mostly see patients for only a few minutes, and during that time the focus is on the illness and not on the impact on patients' everyday life. The key is obviously to see the person and the patient. And I really like that comment. The doctor was responding to a particular comment that a patient made in their narrative, and their response was, "Is that what the patient thought I meant? I wonder why." So there's some very useful learnings in just tracking some of those stories, and there are about 100 of those that are published now, most of them freely available to look at. Schizophrenia, just changing the subject slightly. I was lucky enough to be asked to do some work to look at the concept of recovery in schizophrenia, and through some of the schizophrenia organisations in the ACT, New South Wales, South Australia and Queensland, I ran 10 focus groups with people with schizophrenia in different locations, city and country locations, and then had a number of depth discussions with psychiatrists and mental health nurses. And one of the areas that was very interesting for me was to look at this concept of recovery. And I think we were talking about this earlier on. And again, looking at alignment between what a clinical view of a particular aspect of treatment was, and then alignment with what the consumer view was. And this concept of recovery in schizophrenia is a very, very grey area, as a lot of you would realise. One of the things that psychiatrists were more likely to say was, to them, recovery was more likely to be an absence of symptoms and a return to normality. People with schizophrenia were very, very unlikely to say a return to normality. They were more likely to say it's about keeping busy, being motivated, managing and not getting swayed by the symptoms. So the walls are shifting slightly, colours are different, there's a voice, there's a sound, but not getting swayed by those things. Whereas the psychiatrist was more likely to ask, as the nurse did, do you hear any voices? Are there any sounds? And if so, then they were rated as either recovering or not recovering. And it came home to me when one young guy who was around 19, would go to TAFE each day on the train, have everything reasonably under control, and then manage until the end of the day. And then he would do whatever he wanted to do with the voices. People would even do things, they would say that they would titrate their medications so that on some weekends they could actually have a weekend without the impact of their medication if they wanted to, say, experience something differently. So they would talk about the symptoms, the physical symptoms sometimes being worse than the mental health symptoms. So again, this is part of the patient voice. This is part of the impact that some treatments do have on patients. Another area is osteoarthritis and joint replacement surgery. And again, just through being able to work on some projects and looking at what consumers think about joint and hip replacement, one of the questions we asked people was, how did you get an idea of when it was the right time to actually have surgery? And a lot of people were influenced by their GP's opinion on how much pain they should endure before they should consider surgery. So it wasn't absolute. It wasn't a functional measurement of what they were able to do in their life. A lot of them were influenced, and the majority of people that I came across in these focus groups felt that they had waited too long. Added to that is another consumer aspect, which is potentially looking at primary versus revision surgery. There are other aspects, lists and queues. There are good initiatives where we're able to look at shortening the queues for people by looking at people who are inappropriately placed in public health lists. In Hep B and selecting care providers, similar kinds of voices of the customers. People look for GPs that are fit and healthy. Word of mouth is very important. So let's look at the things that interact the effectiveness that we see between these three parties. Relationships, processes and information are three areas. If we look across the things that we can measure to get a sense of how well these three groups interact, we can look at the way they work, the way they take up technology, and then the way they look at each other in terms of their role. One of the things we see is that GP perceptions of allied health is sometimes quite variable, and trust seems to be one of those issues. GPs have a trust issue in choosing to take a chance in referring to an allied health professional for any particular reason. There is a credibility issue in terms of understanding whether they've got the right area of expertise, and reliability in terms of what feedback they get. But one of the biggest things is the denominator, which is the self-interest that a GP or other health professional may perceive. Take an extreme example. Pharmacists who have a retail interest are often, their role as a member of the treating team is often clouded by a GP seeing them as having a financial interest, which will completely sometimes cloud their judgment on what the value of something like a home medicine review might be. It's an interesting aspect. If you want to read more, have a look at what Charles Green writes about this. This issue is also, this trust equation is something that you can look at in the interaction between allied health, general practice and hospital services. If you then look at what allied health think about general practice, and this is where we've had to aggregate 17 different professions, we ask the question, how well do you think GPs understand where you can add clinical contributions to their patient care? And we see some very, very depressed scores on a 1 to 5 scale. We see a very small number of allied health professionals, just over a quarter, feeling that there is a high level of clinical recognition from GPs. Now, where does this come from? How early in a GP's medical training do they build up this impression of what an allied health professional may or may not contribute? The impact of this is in terms of capacity. It may mean longer or delayed referrals, longer journeys, less reinforcement of health prevention messages, and less capacity. How could this be improved? Education. 471 allied health professionals describe what they think are some improvements, and a quarter of them say education. Tell them what we can do. The other area is the treating team. And I've taken the liberty of just using the model of the Australian Centre for Medical Home used to talk about adapting the model, adapting the team to meet the particular need that a consumer or a patient may have at any particular time. One of the things that we do is we try and get a sense of whether people feel they're part of the treating team or not. Because if they're included in the team, then there's a better information flow, there's shared decision making, their contribution is rated as being more valuable. When we ask allied health professionals, tell me about the sense of being part of the treating team when you think about the GP's team. Their scores are rock bottom, and we've got the bushfire indicator there. You wouldn't be allowed to light a fire with those kind of scores. When we ask allied health professionals, how strong do you get this sense of being part of the treating team from a hospital's perspective? Same thing, get very low scores. GPs have a slightly higher score, but it's still very, very low. They're not seeing themselves as being part of the treating team. And in some measurable studies, in some LHDs, we've actually seen hospital staff who feel that they would be breaking the law if they provided clinical information to a patient's own GP. So this treating team sense is quite an issue. Processes and systems, I don't think I need to say too much about these other than the fact that we have fragmented referral services, the feedback is limited, and we have lots of common processes that don't talk to each other. Here's an example. The number of allied health professionals across these 7 Medicare locals using electronic patient notes hasn't yet hit 50%. The numbers using secure messaging software, again, has only just hit 1/3. So these are some of the barriers if we want to see effective communication of patient information. We just don't have the systems yet that allow that. E-health is the saviour, but at the moment we see everybody lagging behind. And again, 50% of allied health professionals actually respond back and say, I'm unaware of how e-health can help my work. So 1 out of 2 allied health professionals, those 17 different professions, 1 out of 2 people are saying, I'm not really sure I get it and what it's going to do for me. So they haven't heard that message that it's going to help them get to know the patient, spend less time writing down things. Funding, as we saw from that wonderful explanation of how our system evolved as a nation, 64% of allied health professionals rate their working knowledge of the various funding programs that are their meat and potatoes and pay for their living with their patients as low, very low or moderate. So funding knowledge is quite poor, and these are private allied health professionals. Okay. If we look at information access, this is the last area. The sharing of information across these 3 groups is quite suboptimal. And I think there's a complacency on the need for this sharing. The fragmentation in technology and systems, I think there's a limited LHD capacity to automatically share information to anybody other than a nominated GP. It's quite a difficult task to change that. It's hard to get timely information. And I think there's a variable consumer awareness and interest in driving this further, which is why we were talking about consumer voices earlier on. So these are the key drivers: relationship issues, people talking to people, processes and systems, information access. The opportunities are, if we could make even small local changes, we could free up and grow capacity. We could improve the experience, improve quality, and improve perceptions. And this is probably the last slide I'll leave you with. And looking at an example of diabetes, you could look at it from 4 different ways of improving capacity or working on capacity. You could start at a community capacity, increasing health literacy, community support, shifting people from thinking of turning up when I've got a problem or when I'm sick to actually lifestyle management. We tend to spend most of our time in workforce management, skilling up, training up, getting more people. Less time in service capacity, and that's where programs like Health Pathways are looking at developing better flows across services. And then even less time is spent at a systems level. And I think that's where we need a lot of change, particularly where in the early education of clinicians, when we start talking about things like consumer voices, the contributions that different allied health professionals can provide. So those are 4 different approaches to improving capacity. And I'll leave you with that as a thought provoker for our workshop.